as David Chan commented day before yesterday, that one creditable thing is that you have come to China, and the second creditable thing is you have found this room 505A and B. It further shows the interest you have in gaining clinical skills and knowledge. And he very well said that if you can find this room 505A and B, I assure you, you will be able to implant secondary IOLs with confidence. So the introduction of this course is, this is a kind of solo flight. There is no co-pilot on my right and left, but a brother from Indonesia and these two brothers from Pakistan and a sister. All of you are my co-pilots. So my participants will interact and share and will guide me through and will correct me wherever I am wrong. So I am inviting myself, Dr. Ziaul Mazari, to the lecture to proceed with the instruction course. In Wapta Hospital Complex, Lahore, Pakistan, affiliated with Central Park Medical College, Lahore, Pakistan, and I am working there on the seat of assistant professor. And the course is secondary IOL implantation made simple. So, for the sake of discussion, I have divided it into 3 parts. Part 1, background and classification. Part 2, clinical and surgical skills. And part 3 will be the review, and we will interact with each other. So general issues in learning and teaching are: learning without thought is labor lost, and thought without learning is intellectual death. It is a saying of Confucius, the famous philosopher of China. So let's be clear about our objectives, what we are going to gain out of this course, and what is the objective from speaker's perspective and from the participant's perspective. So to demonstrate the safe and effective use of techniques for secondary IOL implantation while avoiding the pitfalls, and to explore the alternatives of scleral fixation of IOL in eyes with partial or total absence of posterior capsule, and to classify indications and to discuss surgical planning for secondary IOL implantation. As I was going through the literature, there is, immense literature and knowledge about everything is here today, but in whole literature I could not find a kind of systematic classification which covers all aspects of secondary IOL implantation. So in this course, I am going to attempt to classify it in a sequential and a clinical related manner, to elaborate variations of surgical procedure required to manage different situations encountered in secondary IOL implantation. And we will go from simple to more complex situations. So upon the completion of this course, I expect my participants to be able to plan a surgical intervention when faced with uniocular or binocular aphakia needing a secondary IOL implant, classify and describe the different clinical presentations and appropriate surgical technique for secondary IOL implantation, identify and manage the most frequent intraoperative and postoperative complications encountered in secondary IOL implantation. Synopsis of this course is that secondary IOL implantation in FX is an established procedure. Variation of surgical procedures are required to manage different situations. The status of posterior capsule varies from fully intact or totally absent. Similarly, the technique needs to be varied accordingly, and that's what we are going to try to cover in this course. The overview is, we will already discussed objectives. Synopsis we have discussed. There will be a little background, and then I will discuss the classification criteria and the classification, and we will be considering pre-op considerations, intraoperative considerations, post-op follow-up, the surgical technique, and then we will be reviewing it. There will be little kind of MCQs in the end, and then we will have a question answer session, and then I will summarize the course. So with this evening scene, we move to our part 1 of this instruction course. The first presentation is about the background and classification. And evolution of cataract surgery, you all know it started from our part of the world in India centuries ago, and then went to Europe, and then came back to us as all other techniques. And this is how it has evoluted over time, from coaching and simple procedures to multifocal IOLs. And here is the man who changed this scenario, the inventor of IOL, Mr. Sir Harold Ridley. And I am a great fan of Mr. Sir Harold Ridley. So he was born, he did this procedure on November 29, 1949, and got this idea of IOL from shattering of the windscreens of the fighter jets in World War II. And those pieces he found in the eyes of the pilot and were not reactive. And then he started working with Mr. John Wright to create an IOL. And interestingly, the first IOL procedure with a PC rent and 2 to 10% risk of posterior capsular rent in good hands have been reported in literature. So these are the situations which demand that we need to know about secondary IOL, PC IOL implantation to give good vision without any risk of complications and with safety to our patients. So aphakia can be classified. This is very basic thing, but this is how we are going to proceed. Aphakia with full capsular support. These are the two major groups on which we are going to base our discussions. And aphakia with partial or absent capsular support. And this aphakia may be further complicated by dislocated or subluxated nuclear fragments or pseudophocus itself. So options for correcting aphakia, you know very well. We have already discussed angle supported IOLs, iris supported IOLs, scleral supported IOLs, capsule supported IOLs, and other techniques like epikeratoaphakia. And we are going to make all others in this section, and we may go in detail in question answer session, but I am going to basically concentrate on posterior chamber IOLs in sulcus or in capsule. So aphakia with full capsular support, what are the considerations? You need to have a look on the pupil, whether it is mobile or fixed, regular, irregular, constricted or dilated because of synecdoche. Iris tissue, whether it's fully intact or it's missing because of the previous surgery or trauma. Synecdoche, anterior, posterior. The visual axis, whether it's clear or opaque. That was about aphakia with full capsular support, with intact capsule. But if the capsule is partial or absent, all the considerations in the previous slide, plus further considerations, posterior capsule, if it is deficient, whether the rent is central, round rent, or a central linear rent, or it is a peripheral rent, and if it is, whether it is totally absent, anterior vitreous, whether it is prolapsed in the anterior chamber or stitched in the wound by the previous surgeon or the previous surgery, or it is already vitrectomized. So these are the things which we need to know when we are planning for a secondary PC IOL implantation. So further complication, as we discussed, the aphakia may be further complicated by subluxated or dislocated pseudophocus. We have to find it out by clinical examination and with the help of necessary investigations, and dispersed cortical matter and other complicated scenarios. So with this background, I have divided this into 5 or 6 groups. Simple secondary PC IOL implantation. This is the term we are going to use, secondary PC IOL. The capsule is intact, round reactive pupil, and The procedure is very simple. Place an incision and implant an IOL. But if there are synechiae, the pupil is not round, so what you need is to perform a little addectomy or just tease these iris away from the capsule, redissect the sulcus and implant your PCIOL. That is sulcus dissection, synechial and PCIOL implantation. And in the third situation, there is a central round rent in the capsule. So you can go perform a core vitrectomy through the rent. Make sure the iris is free, there are no synechiae, and implant a posterior chamber IOL. That is intra-shelf PCIOL implantation, IS-PCIOL, combined with anterior vitrectomy and the leaf. So as we were discussing, if there is peripheral rent and is extending for less than 80 degrees, here I have how will you decide whether your remaining capsule is able to support one of your IOL haptics or not, is whether it reaches your haptic optic junction or not. And how can you assess it preoperatively? By fully dilated exam. If you are able to find that the remaining capsule, intact capsule, is more than 180 degrees intact and the rented capsule is less than 180 degrees, that means your capsule will be able to support the one haptic of the IOL, and in those situations we will classify it as single haptic scleral fixation of PCIOL, HSF PCIOL. Where the capsule is totally absent, the answer is very simple. Double haptic scleral fixation of PCIOL, DHSF PCIOL. And if the aphakia is further complicated by dislocated pseudophacos or nuclear fragments, or the nucleus itself is dislocated, of course it will be combined with double haptic or single haptic scleral fixation, will be combined with some other procedure like PPV, retrieval and fixation of the same lens, or IOL exchange. So with this we come to end with our part 1 of the course, that was background and classification. And are you with me to this point? The classification criteria and the groups we have made, whether the capsule is intact, the rent is central or peripheral, the extent of the rent, the status of the vitreous, whether we need single haptic fixation or double haptic fixation. In this way, whenever we face this, whenever we treat an aphakic patient, we will be able to put it in a certain category and we will go to operation room with a very clear-minded plan.